want to welcome all of you here today. I'm not sure the crowd we were getting, but I'm very pleased to see so many here. It's not the most important issue. It's only healthcare. So I was glad to see that people are interested. I can't think of an issue, by the way, that so little is known of in the way of facts in relative proportion to how much people need it. You know what I mean? Healthcare is something that impacts all of us so directly and so clearly. Yet there's a lot of misinformation out there. There are a lot of opinions disguised as facts. And so what we were hoping to do at the Civic Engagement Institute was to shed some light on some of the facts about healthcare and how difficult it is, especially for those in positions of poverty, to access it. And this is something that clearly impacts our Tunxis community, which is why we decided to put on this event today. And the guest speaker we have is, I would say, an expert on the issue. He is the chair of medicine for St. Francis Hospital and Medical Center in Hartford. He has collaborated with us on a number of other issues. He is one of our mediators between Tunxis and the community at large. The Civic Engagement Institute recently formed the Community Advisory Board, and Dr. Grey is a member of that. And so we consider institutions like St. Francis kind of windows into what the community needs. And that is why he's here to offer his expert opinion on the issue of health care. And so we welcome Dr. Michael Grey. Before you go, give him an applause, I have to mention Cliff Sargis, who actually has known Dr. Grey for many years, and that's why we were able to solicit his help. And so, as usual, Cliff, acting behind the scenes, deserves much more of the credit than he sometimes gets. Aubrey mentioned that his new nickname should be the Wizard of Oz, because he's always behind the scenes acting as the brains behind the machine. So anyway, Dr. Michael Grey.
Thank you. Did you take my slide print out? Thanks. I called Cliff something else. I've worked with him on and off for almost my entire career, and I'm dating myself, but I used to call him Radar O'Reilly. Radar always knew what the colonel had to sign before the colonel knew he had to sign it, or he could hear the helicopters coming. That's Cliff. He always had things completed before I even knew they needed to be completed. So you guys are blessed to have him around. I'm a primary care internist, so a primary care doctor, just by way of what I do for my, being a real physician. Every time I get a promotion, my mother, who's 91 years old, asks if I'm still a real doctor. And I still take care of patients, which is great, because it means I'm inside the belly of the beast, which is healthcare. And even though as chair of medicine, I'm involved with all the strategic planning and all of the policy issues, and it allows me to sort of talk to you today. None of that would be as useful, I think, if I weren't still taking care of patients. So I hope that will inform some of what I'm going to talk about here. I assume everybody knows the reference to the Beatles song about the long and winding road. As I get older, it's unclear whether or not my cultural references resonate or not. So I'm always open to suggestions, so feel free. So what we're going to cover today, a lot of ground, which I'm going to summarize the history, structure, and financing of healthcare in the United States. It's going to be a real mountaintop kind of view. In fact, I'm reminded one of my favorite quotes from Thomas Jefferson is that when you come to the end of your rope, tie a knot and hang on. So we're going to hang on today and cover a lot of ground. I want you to think about all that you hear about healthcare out there, especially as we work our way up into a full fury of an election season, and perhaps learn more about what people are discussing and debating and arguing about, and also maybe question some of the assumptions that are out there in the wind, if you will, based on what we talk about today. And last, because I think what the Civics Engagement Institute is so great, to be more informed and engaged citizens, and I support the work of that group. So we'll get started, I hope. Okay, so quick background, who gets sick and why? We do, whole semesters of talks on the history of medicine, but I'm just going to cover a few things here. Going back maybe from 250, 300 years back to as far as we have any recorded history, the theories about why people got sick really focused on two big areas. One was sort of the humoral theory of disease. People have probably heard the term good humor. That's actually dates to how people perceived healthcare, disease. So you had 4 humors, and they were in balance with each other, and you were in good humor. And when the humors were out of balance, you were in bad humor. And I'm happy to go into more detail if anyone is dying to know about ancients' view of history. But the interesting thing about the poverty connection is that one of the things that people thought caused bad humors was something called miasms. And they often associated the miasms with low-lying, wet, boggy areas. And it turns out that, if you have a lot of swampy, wet areas, you breed a lot of mosquitoes. And so one of the things that people made that association between those miasmic areas and where people lived. And obviously the people who had more money were living up on the hill, like in the castle, for example, and the people who were doing all the rest of the work were living down in the valley and are more exposed to it. In fact, malaria, if you think about the Latin root, means bad air. And so that connection with socioeconomic status and disease has been known really for well over 2,000 years, going back even further. To jump way far forward to one of my favorite people, John Snow was a doctor in London, and there was a terrible outbreak of cholera, which is a waterborne disease. Nobody really understood what the causes of it were, but he very cleverly looked at the addresses of all the people who developed cholera in London during this 1860-ish outbreak that they had there. And he noticed they all kind of clustered around one area. And when he went to that area and saw what was at the center of that, the epicenter, there was a public pump, a water pump, where everybody came from that poor area of London to get their water. So he postulated that cholera was somehow a waterborne disease. They didn't have microscopes, and they didn't know fully about the germ theory of disease, but he decided just to take an axe to the pump and took the handle away, and the cholera epidemic ended. So it was a great example of a sort of activist physician who kind of put 2 and 2 together, did a little shoe leather epidemiology, and had a significant impact. And even though it's not that big here, you can see, no, the light doesn't go, but on the far right, the pump is still there. So if you ever do make it to London and you're interested in the history of medicine, stop by and see the Broad Street pump, it's still there. To leap a little bit further forward yet, to the Committee on the Cost of Medical Care. This is a really interesting study, and I think our understanding of the scientific, if you will, understanding of the link between disease and socioeconomic status really dates to the late 1920s. And this publication, they actually published, I think, 32 volumes. It was funded by the Rockefeller Foundation. They got a bunch of scientists together, doctors, public health people, and they systematically studied healthcare disease in the United States and published this 32-volume report. There's a summary of the report, thankfully, which lays out their most important observations. And the one that I think, for the purposes of our talk today, that are most interesting, and there's a consistent relationship that they found between how much income people made and how sick they were from a health perspective. And then the other second really interesting observation which I'd like you to keep in mind, is that it turns out that people are transitioning from one socioeconomic status to another, actually often do worse from a health perspective. So you kind of wonder, why would that be the case? And it may be that when you are poor and poor all the time and struggling, figuring out how to make things meet, whatever system is out there, you know how it works, because that's all you've got. But if you're in another level of socioeconomic strata and you're used to things going a certain way, when all hell breaks loose, like let's say in Great Depression in 1929 and what we lived through most of the 1930s in the United States, people really had a hard time managing that because it was an unfamiliar world. So that notion that there's a direct correlation between socioeconomic status and ill health and transitioning downward socioeconomic status and ill health is important to keep in mind when we get to some other aspects of our talk. So this is the Q&A section. I've got a few slides like this. So what's the best predictor of good health? You're going to have to vote. Having health insurance, having a lot of money, having good genes, having a good doctor, or having a job. Take a vote of the crowd. Who votes for A, having health insurance is the best predictor of good health? No takers? One person. All right. 2, having a lot of money. If you're wealthy, you have better health. So we have quite a few more, maybe 7 or 8 people. Okay, having good genes, genetics. Got 1 or 2, 3, 4 people. Having a good doctor. Come on, let's hear it for the docs. Yeah. A couple of people. All right. Or E, having a job. How many people think that's the #1 predictor of good health? What is it?
The answer.
It is actually.
No, it's having good habits.
Well, we'll talk.
I didn't expect what it said.
Yeah, we could talk about that in the question and answer section. The actual answer, though, is there's the strongest correlation between good health and all of those factors that we talked about is actually being employed. Now, we can tease that apart. Does it mean that if you have bad health, you can't work, and so it's artificially inflated? We can circle back to that. But in study over study, when people are working, they tend to have better health, and that's also something to keep in mind. So you may be able to see this better than I, but when didn't have them all on the previous slide, but these are all the determinants of health that if you sort of collect all the science and all the research and studies that have been done, these are all the various things that go into health. And you can see income and social status is at the top, social support, employment, physical environment, education, child development, personal health practices and coping skills like this young lady right here, and health services and biology and genetic endowment. And the world that I live in is that health services world. But you could see that my ability to impact the health of my patients is far more contingent on all those other variables that are out there than what I can do when I'm sitting down with my patients in the office. So I put this slide up just to show that how we stay healthy and keep healthy is determined by, maybe 10, 12 factors that are all significant in and of themselves. By the way, I put that slide up. This is a slide from the 1930s, and you may not be able to tell, but there's a sick patient. She actually has a Hispanic farm worker being examined by the doctors. At that time, they all would have been men. And you've got a nurse up on the left there with her hair all popped up. You've got a grandmother, her mother there on the far left. And then there's a priest sticking his nose in on the corner side there. I put this slide up to show that medicine has always been something that's been socially situated. So how people feel, how they react to their health conditions, how well they do, how well they respond to the treatments that they get, are influenced by family, by their own condition, by the health care they get, by other types of health care providers, and of course, I think there's the whole spiritual and religious component, which is very powerful. So what goes on in Connecticut? These are the top, I think, 10 conditions in Connecticut that are considered the public health priorities for the state. You don't have to write these down. You could have come up with this list on your own, maybe with the exception of hospital-acquired infections. But just what I really want to draw your attention to is every single one of these that is asterisk is greatly dependent on socioeconomic status and income. So if you look at statistics on what are called health disparities, and you measure all of these conditions based on your level of income and also your ethnic or racial background, there are stark differences between groups on every single one of these conditions. Yes?
Are these in order or just?
They're in order from the state health department, but actually I put mental health up number one because I read a separate article that said it was the #1 driver of hospital admissions in the state of Connecticut, which I was not aware of. So it's a pretty important problem. Motor vehicle accident, I'm sorry. We use a lot of, so HIV is human immunodeficiency virus or AIDS. MVA is motor vehicle accident, and I didn't do HAI, which is hospital-acquired infections. I did remember to spell that one out. I apologize. Please feel free to interrupt if I use initials. So why are we talking about healthcare anyways? It's all in this slide if you can see it. And what you have here, I borrowed this from a guy named Don Berwick, who was the president of the Institute for Healthcare Improvement and ran for governor of Massachusetts, right? You were there. And what you can see is when you rank countries based on quality, access, efficiency, equity, healthy, productive lives, and the costs, and you sort of look sort of 1 through 7, I think they've got up here, the U.S. doesn't turn out to do all that well. We're usually down near the bottom, and in most categories we're actually at the bottom. And so that's really the dilemma here, which is we spend an awful lot of healthcare dollars. 73, this is an old slide, $7,300 per capita in the United States. For every person in the United States, that's what we spend. The next closest person, I think, is Switzerland. Is he up there? No, but so Switzerland's not up. But we're about twice as expensive as the next comparable Western developed country. So it costs a lot of money. A lot of resources go into it. In fact, if you, it's showing up here, but I'm going to hit the button. It's not advancing. Oh, I have to go back. There we go. 20% of the gross domestic product, approximately, is spent on healthcare. That means every $5 in the United States that is generated by everything that we do across every industry, one of those dollars is spent on healthcare. So it's a big, big part of the economy, and it's a big part of policy conversations for precisely this reason. People feel that we're spending a lot, but not getting what we should for the amount of money that we spend. And I think this is a pretty interesting slide. If you look at the difference, if we cost what Switzerland did over like about a 15-year period compared to the U.S., we could afford to send 175 million students to a 4-year college with the savings that we have. I'll just use that example for this group because they're all in school. Or you could get rid of the debt that we have, the federal debt, turn it into a surplus, or everybody could get 4 iPads worldwide. The point is that if we were even at the next level of spending relative to other countries, we would have a lot of additional resources to spend on other aspects of the economy.
Those produce countries, except for the U.S., all have national health insurance?
Most of them do, but they look different in each country, and I could explain that further. So what does that actually mean as a practical matter? Again, borrowing from Massachusetts, Connecticut is not that much different. If you look at all the other things we spend health dollars on, revenue at the state level, looks pretty flat. Those are all the lines at the bottom. The one line that's going up year after year after year is the money that Massachusetts is spending on health care. And when you take it the next step and look at the percent change in spending, every other sector of the Massachusetts economy or the things that they need to spend money on, education, correctional, safety, you name it, environment, recreation, everything's going down, so some of it really did, except for healthcare. So more and more money is going into healthcare, and it's sucking resources from every other part of the economy. So that's why people fight about it, because for all the money that's going into healthcare, it means you have less money to spend on building bridges, expanding schools, providing support for people to go to colleges. You name it. So it's a big problem, and that's it sort of in a nutshell. So my next part of the talk is kind of how did we get where we are? This is where you have to hang on to that knot that Jefferson talked about. So another Q&A. Who was the first president born in a hospital? If anybody knows right now, you can shout it out. Here are your choices. Thomas Jefferson, Abraham Lincoln, Roosevelt, Kennedy. Don't, just because it spins the most, I am not that clever with technology, it's not a hint. Kennedy or Jimmy Carter? So how many people think Jefferson was born in a hospital? Nobody, right? Lincoln? Honest Abe? Okay. Franklin Roosevelt? John Kennedy? A couple of hesitant hands. Jimmy Carter? Nobody wants to. There's no penalty here. I'm not going to quiz you on it. No, it's not. It's just a mistake on my part. It was Jimmy Carter. Isn't this interesting? So we all think about hospitals as being such a big part of medicine, and we're going to talk about it a little bit more detail in a second. But Jimmy Carter, probably most of you weren't born when Jimmy Carter was president. You all look like you're maybe in your mid-30s. But anyways, when I was your age, he was the president. He was the first one who was actually born in a hospital. All the presidents before Jimmy Carter, going back to the founding of the country, were born at home or in a cabin, or probably Lincoln had the worst of it. So, next question. We're going to cover this in this section, but I want to get you guys, I want to see some more hands go up this time. When were we closest to passing comprehensive health insurance reform, universal insurance or national health insurance, whatever words you want to take? You've got three choices. 1935, 1965, so Social Security Act was passed in 1935, Medicare and Medicaid in 1965, or in 2010 with the Patient Protection and Affordable Care Act, or sometimes called Obamacare for short. So who thinks A? 1935 and Social Security, Great Depression, New Deal. No, two tentative hands. 3, 4 hands, okay. 1965 with Medicare and Medicaid. So everybody's really familiar with those two. Good. And how many think, oops, I'm sorry, I didn't get to see. Did we have any takers for Obamacare? Yeah. Actually, the closest we came was really in 1935, 1936 with the Social Security Act that was passed by Congress. There was a provision in that, the original legislation that went to Congress for national health insurance. It was in there. And it's an interesting story, depends on how you want to read it, but the bottom line is that organized medicine in the form of the American Medical Association was so upset about this provision that literally every doctor in the country was asked to speak to their patient and tell them what a terrible idea this was, and to then expect that their patients would go talk to their legislators. And then the bottom line is it was taken out of the bill because Roosevelt was afraid that Social Security Act, which was a paramount desire for him to pass, would not pass. But that was how close we came, within a whisker of universal coverage in 1935. And we haven't come closer to that since, and we'll talk about why. But that's literally almost 100 years ago. I don't know why it did this, but this is just, I didn't know how to undo it. So So a little bit about medicine and healthcare in the next several slides. Before 1900, you pretty much, all you had to do was to hang out with a doctor like me for about a year or two, and you could then put out a shingle and practice medicine. It really was the wild, wild west. And it was more typically west of the East Coast, if you will, where you didn't have to have formal training. You really functioned, you could call yourself a doctor with apprenticeship training. And I like this quote from Oliver Wendell Holmes, whose son went on to be a Supreme Court justice. I firmly believe that the whole materia medica, and that's what they called pharmacy back then, materia medica was, as now used, could be sunk to the bottom of the sea. It would be better for mankind and all the worse for the fishes. There was not a lot of confidence that your interaction with a doctor would have any positive impact on your health. In fact, it was about 50-50 that you would have any benefit from your physician until well into the late 1800s and really into the 1900s. And part of it had to do with there weren't a lot of tools. Really, even the germ theory of disease didn't come around till the 1860s, 1870s with the work of Louis Pasteur in France. But physicians didn't adapt really early to the new science. It really didn't happen until well into that 19th century and into the early 20th century. And so it was a bit of a crapshoot when you had an interaction with a doctor until well into the last century. However, things did begin to evolve, and as the science of medicine got better, society started to pay more attention to how they regulated it. In the 1900s, actually, the AMA tried to get passed that you had to be a medical doctor with a 4-year university degree to practice medicine, and none of the states nor the feds were willing to accept that as a definition. They just didn't have enough clout then, and there wasn't enough, I guess, support for it based on the actual quality of care that was provided. But it was a real battle at the time, and state by state, eventually, there were licensures that you had to go through, which we still do now. In order to practice medicine, you have to have a license, and a lot of other things you have to have a license as well. But that came very late in the game. The other thing that happened, really driven by World War II and in the post-war period, was centralization of care. I told you that most of the presidents were born at home. Doctors used to make home visits. That's how most people got their care. Even in poor urban areas, resident doctors from the hospitals would go around with ambulances and go to people's apartments and take care of people there. And if they needed to come to the hospital, they would bring them. It really wasn't until the latter half of the 20th century where their hospitals were a common feature of medicine and healthcare in the United States. A lot of it was driven by something called the Hill-Burton Act, which funded hospital construction in the post-war period. And the other part that came along with that was medical specialization. I'm a primary care, they used to call us general practitioners or GPs. Until well into the 20th century, the vast majority of doctors would have been generalists like myself. After World War II and in the post-war period, medical specialization really accelerated. So you started getting cardiologists and gastroenterologists and endocrinologists and specialized types of surgeons. But all of that was a really relatively late development. But it was important because specialists are not going to go make home visits. You're going to have to come to them. So specialization and hospitalization and the centralization of care around hospitals really was driven in that post-World War II period. And that's kind of when you think about it, it's still a very dominant feature of healthcare in the United States today. So who paid for healthcare back then? I told you a little bit of what it looked like and how it developed. Well, prior to 1900, most of it was really a cash transaction, fee for service. If you asked me to come see you, I would charge you some money. You would pay me. And by the way, bartering was not unusual. In rural areas in particular, I might get 10 chickens to come deliver a baby, and that was considered sort of a fair trade. Otherwise, it was paid in cash. There were some innovations at a smaller level, trade unions, industrial guilds, specialized workforces, if you will. They often had enough clout and power to set up, even within the trade unions themselves, a fund where people would put a little bit of money aside each month in order to support health care expenditures that might come up. It was a form of insurance. They actually called it sickness insurance or sickness health insurance. And that's kind of the state of affairs until the early part of the 20th century. And the first push for national health insurance came as part of the progressive era. There were a lot of things going on socially at that time, but health insurance was definitely part of the conversation. The problem was that people associated it with socialism and Bolshevism, and so it didn't gain a lot of traction in the United States, but other reforms were enacted, like the workers' compensation program that some of you may be familiar. That system started at the same time. That was, if you will, sort of the trade-off for, as opposed to health insurance, which people stayed away from, at least the government did. The next really big push for national health insurance came in during the Great Depression and the New Deal. I don't know how much history you all have had, but think about 1 in 4 of you being unemployed in the 1930s. That was sort of the average amount. So 25% of the population was unemployed. It was a very dire time. And along with that Social Security Act, which was designed to provide some income support for older people, there was the expectation that national health insurance would be part of that bill, as I talked about earlier. It got pulled out again and then reintroduced, actually in an expanded format, as a standalone bill 3 times in the early 1940s, during the middle part of World War II, towards the end of World War II. They were called the Wagner-Murray-Dingell National Health Insurance Bill. I think Dingell's son or daughter is actually still a congressperson from Michigan, so it's still around. They submitted the bill 3 times to Congress, and it never came to the floor for a vote, not once. It never got out of committee, each of these bills. So it's interesting, people talk about national health insurance and that sort of legislative process. The fact that the bill was actually created, had a fair amount of support, but was shut up in committee, so that the full House and the Senate never had a chance to actually vote on universal health insurance during the time when, at least in my opinion, was the most likely to pass. So what happened after the war? This was really when I think the present state of healthcare in the United States crystallized. You know, I told you that we had 3 national health bills that were submitted in the 1940s, and they didn't pass. So what happened instead? We started to see the development of commercial or private health insurance in response to the need for people to have access and to be able to pay for health care. This is a point worth, most people have heard of Blue Cross Blue Shield. So Dallas teachers in 1939 got together and created the first Blue Cross plan. It was teachers. They paid $6 a year, and they got 21 days of hospitalization for their $6 a year. A few years later, out in the Pacific Northwest, around some of the lumber and mining areas, the workers got together and similarly took a certain amount of their paycheck each month, put it into a pool of funds, and created an insurance pool to pay for health care. And that ultimately morphed into Blue Shield, which is more the non-hospital part of Blue Cross Blue Shield. Blue Cross Blue Shield has evolved dramatically since I was much younger, but it's still around, and it's still a dominant player in the commercial market. But the main point I want to make is this post-war period is where health insurance was extended to a much wider population of the American people, but it was done through their employment relationship. So the Dallas teachers, or the lumberjacks and the miners. Ultimately, Blue Cross Blue Shield became a product that could be sold, and you would buy health insurance for both hospitalization and non-hospital expenses. That's when the commercial market in healthcare really took off after World War II, and it continued really unabated through the 70s and into the 1980s. And so if you take a step back and think about where healthcare is today, the majority of people in the United States are covered by private or commercial health insurance. And there's two big chunks paid for by Medicare, which we can talk about in a minute, and Medicaid. And then there's a small percentage of people who are without any insurance at all. But really, between commercial insurance, Medicare, and Medicaid, that's where financing of health care is today. And as the next bullet on the slide shows, Medicare was passed in 1965, and thereafter Medicaid. Medicare is focused on older Americans over the age of 65. By the way, it was not that common for people to live much past 65 in that time. And yet, all of us probably know many people in your own family now who are living well into their 80s and beyond. My mother's 91. She never goes to see doctors and hasn't been hospitalized since my sister Julie was born. She's like the perfect Medicare patient, never needs them. But it's really for older people. But they never thought that that many people would live that long, so they set the age at 65. Medicaid has always been focused on people based on their income. It varies from state to state because it's a state-based program with some federal rules that are set. But basically, if you're about at 140% of the federal poverty limit, you're eligible for Medicaid. And some people are eligible for both. They can both be poor and old, and they are called dual eligibles, and they have coverage. And then the last, I think, major change in healthcare financing really came in 2010 with the Patient Protection and Affordable Care Act, also known as Obamacare. But like Medicare and Medicaid, they were really built as an extension of an existing model. So Medicare and Medicaid were built as an amendment to the Social Security Act of 1935, and Obamacare was built as an amendment to the Medicaid legislation. And really what they did was they offered an incentive for states to expand their coverage state by state. But the point that's up there is that there weren't any changes in the structure of healthcare based on passing the Affordable Care Act in 2010. It really was a way of expanding that safety net to include people who were otherwise excluded and incentivizing states to take the federal money in order to extend the benefit to more individuals, which it did. But it didn't cover everybody. So if you look and take a step back and see where the money comes from and goes to today, there's a lot in this slide, but a typical hospital like myself, almost 70 cents of every dollar comes from a government-sponsored health insurance program, either Medicare or Medicaid. The other 30% comes from commercial insurance. Most hospitals would like more commercial insurance and less of the government-sponsored, and the reason is on the far right. For every dollar we charge for a service in the hospital, Medicare pays us about 80 cents on that dollar. Medicaid pays us about 60 cents on that dollar. Some places it's a little lower, some places a little bit more. And how do we sort of make up that difference? Because it's 70% of our revenues. We make up our difference by, if you will, adding the expense of commercial insurers and paying for their employee-based contracts. So on average, we'll charge Connecticut or Blue Cross Blue Shield or United or Aetna $1.20 for every dollar's worth of service that we sort of benchmark for. And that a little bit of extra that we get under the commercial plans helps subsidize the hospital's losses in, if you will, in caring for Medicare and Medicaid patients. And that's not something that is widely understood. We could have a real good debate about whether the cost of health care is correct and it shouldn't be that expensive, but I'm telling you, this is how the system works right now. 55% of the population is covered by commercial insurance. That insurance cross-subsidizes the rest of the system in order to provide care to the elderly and to the poor. That's the trade-off and how we've done it in the United States.
So what do commercial insurers tell it then?
Well, because their clients, if you will, they're the people that are buying those policies for their employees. They want access to health care for their employees as a benefit, and they're willing to make that bargain. But some of you may remember the big fight, maybe it's been about 2 years now, between Anthem Blue Cross Blue Shield and Hartford Hospital. They went to the mat. It was a death match because Hartford wanted them to pay more under the contract, and Blue Cross Blue Shield didn't want to give them that. And they literally went toe-to-toe, and ultimately Anthem said, okay, Hartford, you're out of our network. We're not paying for patients to come, or if they do come, you're going to have to pay more. Ultimately, it got settled, and they sort of split the difference. But in this day and age, you're going to see more and more battles between the commercial insurances and the providers of health care because they're looking to get more, if you will, money in the premium in order to deal with the money that they don't get through the other payers. And obviously a bigger issue for some hospitals, like my hospital serves a very poor part of Hartford, and it's a bigger deal for us than it is if you go, say, to Middlesex or to Greenwich, where the hospitals are in an area where they're pretty well supported, and they don't see as much Medicaid in particular. So we've covered a lot of ground. Any questions on that so far?
Just you mentioned the uninsured, doesn't that take a big toll on not-for-profit hospitals? Are you required to see and then to walk?
Yep, I'm getting to EMTALA, but thank you for that. But you're absolutely right. It's about 5 or 6% of total costs go in most hospitals, on average, for uninsured patients. And as we'll talk about in a minute, if someone shows up at a hospital and needs and requests care, you're required under law to provide that care. And we'll talk about the pros and cons of that. Yes, Raphael.
I think I never understood. Maybe it's so obvious that I don't quite get it. But Medicaid is based on need, right? So it's a need-based system.
Yeah.
And yet we have millions of people who are uninsured. A good portion of them are poor. So if they are poor and they need health care, why can't Medicaid simply identify those people and supply the millions who are uninsured with the health care they need?
There's a complex answer to that, but I'll tell you one of the drivers of it is Medicare is a federal entitlement program. If you're a citizen and you've been working for 10 years and paying into Social Security as part of your taxes that get taken out of your paycheck, you are automatically entitled to Medicare once you hit the age of 65. You can push it back a year. And you can move it up a little bit, but your benefit is different. Medicaid is a state-based means-tested program. That means all 51 states, 50 states, then Puerto Rico, so Commonwealth, they have their own rules. Connecticut's rules are different than Massachusetts. They're way different than Mississippi. So the benefits, the threshold for what you are eligible for, all that is driven by the states with certain broad parameters that the feds require. And one of the things that happened with the Obamacare, which people got very exercised about, was there were a lot more rules in order to get that extra money. So there are certain things you had to cover that some states heretofore had not felt they should cover. And I won't get into all the potential weeds there, but let's just suffice it to say that the state-based decisions are ones that are very important for how Medicaid runs in any given state, whereas Medicare is pretty standard around the country. And for that reason, it's interesting, almost every hospital participates in Medicare and really Medicaid by sort of default, but physicians do not. So I, as a physician, if I were in private practice, I can accept any insurance that I want and not accept other insurances. So if I'm only getting 60 cents on the dollar and I'm a gastroenterologist, I'm not likely to really want to take a lot of Medicaid patients. I might take Medicare patients because if you didn't have old people coming to see you, you're not going to have a lot of business. But commercial insurance and Medicare, yes, although not, it's interesting, we see a lot of physicians not even that happy about Medicare. But Medicaid is a problem. So patients who have Medicaid have much more limited options in terms of where they can go for health care. And my own personal opinion is it's not that they don't get health care or don't get access, it's just going to be way different access and timeliness than what I can get as someone who's commercially insured through the state of Connecticut because I'm a retiree. Did you have a quick question?
Yeah, isn't it true that at least half the people that are uninsured actually could afford it? And that's why
Choose
they
not
qualify for Medicaid.
Yeah.
They just choose not to.
Yeah, people roll the dice because they think, especially, you know, who is not using a lot of health care? You guys. You're young, pretty healthy. Maybe you go for a checkup. But if you look across the board, young people don't need as much health care. As you get older, obviously, you need more and more health care. So if you're young and you've got you know, with or without a family, whatever, you're figuring out how to use your money as wisely as possible. You may elect not to choose to do that. I have a son, my youngest son, he works as a teacher in Newington, not full-time yet, so he doesn't get benefits. He says he can't afford the Husky plan. It just, the finances don't work for him. It bothers me a lot. I may have to pay for it. But the fact is he's choosing economically rationally. He's healthy, doesn't think he's going to need it, so he doesn't pay for it. And that is part of the problem with our current system. And it was even the cause of some of the biggest debate around the Affordable Care Act, the Obamacare, because there was a component in there that said that if you don't buy health insurance, all of us, you are eligible for a penalty. And because that's how insurance works. Everybody pays in, but only a percentage of people ultimately end up needing it. So in the end, you sort of share the risk across hundreds of thousands or millions of people for the tens of millions of people who are ultimately going to need it. So, but we don't do well generally in the United States with mandatory anything. It always is always a big debate, and we can talk about that. I want to go over this one real quickly because a lot of people think hospitals, it's like a, you know, super high revenue kind of business. So I put up just to give you an idea that there's a very narrow profit margin in most hospitals. People, don't get me wrong, a lot of money comes in. But in order to run that ship well, costs a lot of money. So for an average small business, your profit margin is about 7. Tobacco, I can't believe they're still making this much profit, but they are 43% profit they make year over year. But in healthcare, a lot of hospitals have 0 margin, 1%. A really banner year is like a 4% margin. If we hit a 4% margin, we're like ecstatic. But think about that. You wouldn't, if you were an investor looking to fund your retirement, you would not put your money into healthcare with a 4% return. You're going to go for big tobacco. Just kidding. So, coming towards the end of this part, our healthcare system is very fragmented and pluralistic. There's a lot of duplication and redundancy. It's very high quality, and spend a lot of time talking about the quality, but I'm happy to answer questions about it. It's very innovative. If you look around the world at where most of the new ideas in healthcare, even healthcare delivery, medicine are coming from, the U.S. for the last 100 years has been a dominant player in that. And I think there's a direct correlation between the fact that we have kind of a freewheeling, non-one-size-fits-all healthcare system, so that people do innovate around the edges and come up with things that aren't done elsewhere. The example I threw up there, 2 of them. One is with almost 2/3 of all the Nobel Prizes in medicine and physiology have gone to the United States in the last 50 years. It's amazing. And at St. Francis, we have a Center for Multiple Sclerosis that is very interdisciplinary, very innovative and interesting. And it's caught the eye of Oxford University in England because they have nothing like that in the entire United Kingdom. Like, I'm not just talking about London, I'm talking about in the United Kingdom, they have nothing that looks at all like the Mandel Center for multiple sclerosis. So they've come over here, we've signed an agreement with them, we're replicating what we're doing at St. Francis for the Mandel Center in Oxford. And one of the things that the people who come over tell us about the National Health Insurance, which does provide universal coverage in England, is there's no money for innovation. There's no money for new ideas. And so they have a budget they have to live in that they get from the government. And once they hit that budget, that's it. And so it's an interesting part of the conversation about which direction we need to go in healthcare, because there are pros and cons in any system that you look at. Was there a question over here? Yeah.
Well, if we're so innovative and great, how come these rankings have us at the bottom? They're not measuring everything?
They aren't measuring everything. So the stats that they use to populate those, I would call them population health statistics for the most part. And so if you look at everybody all across the Netherlands and New Zealand and the United States, we are not going to fare well because there are huge disparities that we talked about earlier in what people can gain access to. But on the edges of where medicine and healthcare are going, personalized medicine, cancer treatment, which has been revolutionized in the last 10 years with all the biologics that you see people advertising all the time on TV. Those are, not everybody has access to those technologies and medications, right? And it's not included in that. So that's to me, that's essentially a big trade-off, is where's the innovation going to come from if you change the way the system is funded? It is having to do with quality of care, yeah. But it's kind of interesting, if you look and see how people decide where to go for health care, how many of this people in this room go to the public websites and look at the ratings and rankings for the different hospitals that you go to? Couple of people. So that would be what? Leapfrog, CMS star ratings, IBM Watson, Health Grades. Yeah, Health Grades is actually what patients write. So if I have 4 responders to Health Grades and one person hated my guts, I'm going to look bad. But there are places that compile data, by the way, and you can go, and I encourage you to, because actually St. Francis looks really good when you do. But Medicare compiles that data. You can actually find out what Medicare has on any doctor that you see, as long as they're take Medicare patients. So you could look me up on the cms.gov physician website, and it'll tell you whatever data they've got on me, they'll tell you how good I am in comparison. And they do the same thing with hospitals. So Medicare does it. Outside agencies like Leapfrog, which is the quality and safety and independent, does it. IBM Watson, most people know about IBM, and most people know about Watson Health, but they look at, they just look at data. They don't even, some of these things you see like U.S. News and World Report, which we're on also, but that's, reputation drives about 25–30% of that rating. So if you're at Johns Hopkins or Mayo Clinic or Yale, you're going to beat reputation every time. But if you actually just look at the data, things start to look different. I think the view inside of the belly of the beast where I'm at is that in 10 or 15 years, this younger generation of much more computer, tech-savvy consumers will change a lot of what's happening in healthcare, and they will be more likely to choose based on some of that data. I think we're gonna find out. Yeah, the regulation is an issue. I'm happy to answer questions about that. So someone mentioned EMTALA, sort of mentioned EMTALA earlier, but so I think everybody knows not everyone in the United States has health insurance, but it turns out that everybody has access to health care. So you do hear a lot of this out there, particularly in the political sphere, that, you know, people, if you do this, people are gonna die. If you do that, people are gonna die. In my view, none of that is actually true. If you're sick and you need health care and medicine, you can go to any emergency room in the United States. And because it's an emergency room under the EMTALA Act, which is the Emergency Medical Treatment and Active Labor Act, since 1986, Ronald Reagan signed it into to law, you cannot be turned away and you will get the care that you need. You have to. They're not allowed to transfer you unless it's to a higher level of care. And so you can always get emergency care whenever you show up. Now, you remember, I didn't tell you that it would all be paid for. I'm not telling you you're not going to get a bill. I'm telling you that if you needed the care, you would get it. And by the way, it doesn't matter. That has nothing to do with whether you're a citizen, whether you have insurance, nothing. I have 3 people in the hospital right now. One's been in the hospital for more than a year. I don't know what the proper term is, but is an undocumented worker, has no health insurance, no family in the country, and is unable to care for himself. And so we have no place to get him to because he doesn't qualify for any of the public payers because of his status. And so we take care of him. And we have people who stay for months, sometimes even more than a year. But if they show up and they're in extremis and they need care, everything that we have to offer, we're required to give, and we do. So I think it's important to keep that in mind when I think sometimes people do exaggerate a little bit about what the impact of this health reform or that health reform is. The truth of the matter is we've had a pretty I hope you've figured it out since we've been talking. Things haven't changed radically since the 1940s in the United States in terms of how healthcare is structured and financed in the United States. We have nibbled around the edges, we've expanded some stuff, we've contracted other things. It waxes and wanes, but we've not had the big conversation about if we're going to go from an employer-based health insurance, system to one where there's universal coverage, and if we are, how we're going to pay for that. And that's also a big deal, because if you want to pay for what we can actually provide, it's going to cost a lot of money. And so what I always tell people, I used to support the idea of national health insurance. The problem I see now is it would mean starving every other sector of the American economy in order to fund what we have normally provide in healthcare nowadays. And the only way it wouldn't happen is if we deny certain types of care to people. And Americans don't tolerate being told they can't have what exists. That's it in a nutshell. You can provide it, and it's expensive, but if you're going to provide it to everybody, then the cost is going to go up. Or you could say nobody gets it, because we have to be fair, and people don't like to be told they can't have access to stuff. They don't like to be told that they have to wait for care. So this is it. I think this is my final slide. I think if I asked everybody, should everybody have health insurance in the United States, I bet everybody would agree that would be ideal. So then if I ask another series of questions, would you change that? So if you had to wait longer to get care, like in Canada, if your grandmother needed a hip replacement, it might take her 6 to 9 months on average in Canada to get that hip. She could get it probably within a few weeks down at the Connecticut Joint Replacement Institute at my hospital. If it meant less innovation in terms of healthcare, if it meant that the overall quality was lower, and by quality I mean not the population health data, but the other. And if you meant that you would be not taking money away from other aspects of the economy, like building roads and bridges, public safety, education. I put the Merritt Parkway in there because I mentioned the New Deal earlier. Have any of you ridden on the Merritt Parkway? Do you know when it was built? It was built during the New Depression. Yeah, the New Deal in the 1930s. And the interesting thing, this is what I love about this story. Every bridge over that highway looks different. Check it out next time you go. And you know the reason why? They wanted to employ architects.
but they didn't want to give it to one architect who did all the bridges the same on the merit. Each bridge was designed by a different architect so they could get a little bit of cash. I think that was really cool. So next time you drive down the Merritt, look at the bridges as you go by. They're all different, all the way to New York City. So that was my goal. I hope I covered most of it. And I'm going to end with getting back to the Civic Engagement Institute. Every government degenerates when trusted to the rulers of the people alone. The people themselves are its only safe depositories, and whenever the people are well informed, they can be trusted with their own government. That's what we're about here. I think it's great that there's such a good crowd here, that you all are involved in thinking about your education, about your role in the world. The work that the Civic Engagement Institute is doing, I think, is really terrific. Any guesses on who this was? Yeah, it was Jefferson. I gave you an ABC, but it wasn't mine. You know what the average age of the people who were at the Constitutional Convention was? It's really depressing. Yeah. It's depressing when you think of people like did something like that. It's like an old Tom Lehrer joke that says it's sobering to remember that by the time Mozart was my age, he'd been dead for 3 years. Questions from the group? I don't think I can get you two, but I always end most of my talks with a clip from Star Trek IV, you know, where they get the whales. Yes. Yeah. And there's a scene where Chekhov gets hurt trying to get some plasma from the nuclear vessel. And Bones and Jim, they show up at the hospital, and Bones is so upset because it's 20th century medicine. And he's like, don't leave him in the hands of 20th century medicine, Jim. You know? It's a great scene, and it always reminds me, and that's my point, is you should have a lot of humility when you're thinking about, you know, medicine and healthcare and the way we do things now. Because, you know, in 2400, when Bones and Jim are out there traveling space, half the things, or more than half the things we do now will seem, you know, so archaic and even barbaric on some level. So take everything I said with a big grain of salt. Happy to answer any questions. Yes, Raphael.
I think what we've seen in the last few years is the proliferation of these medical clinics in and around the area. Oh, yeah. Right? I'm just wondering what that symbolizes, number one. And number two, what the consequences are in terms of the quality of care.
I skimmed over that, but one of those last slides, there are many places where anybody can present to get care, in addition to the emergency room. I did talk about EMTALA. So community health centers have expanded dramatically in the last 5 years with support coming out of the Affordable Care Act. But they've been around since the 1960s, actually. And anybody can present to a community health center for care. And in my opinion, especially in this area, the quality of care that's provided at CHS or CHC or Wheeler Clinic is really excellent. Part of it is that we've built sort of a floorboard for quality in this country, so you can't really get into the game, if you will, without providing a bare minimum of quality expectations. But I've had a lot of interactions with community health center. I used to run one up in Massachusetts in Springfield, and overall the care is very good. They struggle not so much on the primary care aspect of it, so the basic care like most of us would need, straightforward things. When someone needs advanced care or treatment, like see an orthopedist or a dermatologist, that's tough. You're gonna have to come to a hospital like mine to see specialists like that, because we do pay our doctors, even many community doctors, to provide all the services that our patients do need in the teaching clinics. So that's how we manage that community mission. At St. Francis, Hartford's the same, UConn's the same.
Primary care doctors, are they okay with these clinics? It seems that they provide competition. Most people are going just to the clinic
No, doctors are so exhausted and tired. They've been, you know, even just dealing with the electronic medical record, again, it's old hat to you. I didn't work on a computer at all until I was 30 years old, just so you can understand. Some of these people are like, oh, are you kidding me? It's true. I was 30 years old when I had my first Mac, which worked well for me because it was very user-friendly. But so, and most physicians, if you look at the aging of the workforce in healthcare, most doctors, the average doctor is in their mid-50s and beyond, so they're kind of my age. We're having trouble replenishing the workforce, which is why I also think you see the growth of nurse practitioner programs and physician assistant programs, which I think is a great development. There are just not enough of me to go around, but I can work with a great APRN or PA to care for way more people than I can see on my own. So I've not seen a primary care doctor ever get it all bent out of shape when the community health center opens up. We're not competing essentially for the same patients. Specialize in?
Who are specialized in particular kind of care, like orthopedics, they seem to be operation with the hospitals, and they used to be a lot of the performing prior to obviously, and now there's a lot less of them.
Yeah. I think what you're referring to is sometimes doctors will get together and form a company, build their own outpatient operating rooms, and then compete directly with the hospitals for commercial business, basically, because they're not taking anybody with Medicaid or uninsured. And I think from a policy perspective, that's very problematic, because all that means is people with more means are being skimmed off and cared for by these, ambulatory surgery centers, if you will. And we don't have the ability to discriminate, not in my hospital, in most hospitals, we can't discriminate based on people's payer source. So if you walk in the door, we take care of you. So it is a problem when those things crop up, but we still live in a free market economy, and it affects healthcare in the same way. There was a push to try to limit those in some of the legislative areas that was not successful. You can imagine there's a lot of power pushed up against it.
I'm not aware that all these clinics in fact do not take any Medicare patients.
The community health centers definitely take no
Some of
Medicaid.
the specialty clinics do it.
Some do, but in my experience, not most of them. But I think, some of it probably depends on the individuals who created it, because there are some of them who are just, they're so tired of being part of something big and corporate, they just want to own their workday. And some of them are motivated to take care of anybody regardless of their source. I certainly know people like that.
Well, just quality.
It's not the majority.
Is there a difference in quality of care?
All of those places have to meet the same standards that the hospital would. So if you're asking me, are they safe places to go? Are they basically as good as any other place you get? The answer is probably yes. The experience of care is probably better because it's going to look a lot snappier than the operating suites at my old hospital. I work in a building that's 105 years old. Because all of our money is not going into my office space, it's going into stuff that we directly care for patients. But if you're building a brand new facility with private funding or equity funding, you can build a beautiful facility, and who wouldn't want to go to a really good-looking facility?
Can you talk about how the sort of the rise in mental health issues is affecting hospitals? Since mental health is not something you can fix like quick with a pill or a surgery.
Yeah.
Healthcare charges that you can't get therapy, whether you're a veteran or you can't go get what you need. It's not an insurance plan to the employer, it's not an insurance plan that you signed up for. So how even that trust ID that you don't even have a health plan?
Mental health services are not covered as robustly in almost any insurance plan that I know of compared to you know, if you had heart failure or high blood pressure, diabetes, it is, you know, maybe you get 10 visits over 3 months, whatever. It's much more difficult to get that coverage, you're right. And that's why I think people end up defaulting into hospital emergency rooms because they can't gain access to it.
When they self-medicate
And-
and hurt themselves on this.
And then also in the field itself, it varies a lot whether both dentistry and psychiatry have not gone all in on insurance in the same way that most other medicine is done. So you have to, you know, it's up front, you sort of know you have to pay out of pocket if you want to see this particular psychiatrist. They can bill your insurance, but then you have to pay the balance of that. So you're right, it's a big problem because the problem itself is going up, as you saw very early on, but our ability to address it, and certainly insurance to cover it, is very sketchy. And actually, a lot of hospitals have gotten out of the business altogether and are outsourcing behavioral health and mental health services because they can't afford to continue it.
I know your hospital is very limited, I mean, is it one of them that has a children's inpatient,
It is.
and there are a lot of kids that need.
Yeah, in fact, last year, we had a review by the accrediting body, the Public Joint Commission. They're the ones just that come around and review everything in the hospital. It's usually a 1-week process. They open drawers and stuff. And we got cited for popsicles that weren't in the box. I mean, it's really, talk about expenses, not really valuable. But one of the things that they complimented us on was that we had continued to provide behavioral health services and psychiatric services once they go all around the country and they just see hospitals just outsourcing that left and right. And the fact that we didn't was a point in our favor. But you're right, it's still, it's not good.
From the capacity, you don't have the capacity, but they need that.
Yes.
What do you do when, say you have like a person who has an addiction problem or alcohol problem and they come into the ER, you treat them, you just, treat them and then they go back out into the community, or do you have special addiction doctors?
You talking about my hospital in particular, or like across the state or the United States? I think as a general rule, you could say that capacity for addiction-related conditions is well below the demand. I think everybody's very familiar with the opiate use, problem or abuse problem in the United States. It's starting to turn the corner a little bit, but right now the ability to respond to the demand, it's a complete mismatch. So the demand is really high, the capacity is really low. And so what you end up having is, kind of the meet 'em and street 'em thing where you just stabilize people. You might refer them to an outpatient program. That requires an action on their part to follow up with it. It's not a warm handoff usually. We have a little bit of a better system at my hospital just because we work closely with Mount Sinai and the behavioral health department, but it's nowhere near as robust as it needs to, and the same thing is true for alcohol. We've got real limitations. And that's actually, and we're actually, if you will, nicer than most of the other hospitals. We have an admission rate for people presenting for alcohol detox that's 5 to 10 percentage points higher than our competition hospitals that I won't name, which is, I think, a sign that we kind of bend over a little bit in that direction, and maybe because we're a faith-based hospital. But the truth of the matter is, no one's doing a great job of this. And I know from personal experience.
With commercial insurance, is there a relationship with in and out of network insurance within like the emergency room?
That's a great question.
Because, for example, if I chose a hospital that was in network with my insurance, but let's say the physicians that were in the emergency room treating patients worked with like an outside, like a third party like agency, I've seen that before.
So the answer is it's the door you go into that really matters. So if there are groups like somebody mentioned orthopedics, but there are emergency room groups that are private corporate groups, and they hire people and they put them in different ERs and they staff ERs. They're not employed.
Right.
our ER docs are employed, but there are other hospitals where the ER docs are not employed. But if they're working in that emergency room and that hospital takes whatever that insurance is, they're gonna be able to bill under that insurer. I thought you were asking the question, which is, it's coming, it's not common now, but the insurers are going to start steering patients based on quality and cost, so-called value equation. What's value? Value is how much quality you get for the cost. So if you are a really great hospital, but you cost a lot of money, that value equation doesn't look that good. But if you're a really good hospital and you don't cost as much as another hospital, the value will look higher. And institutions are starting to steer people to high-value hospitals. My hospital happens to be one of them, where we just have had conversations with the state of Connecticut, with the city of Hartford, with a number of different employers, because they're looking for a good price on a hip replacement with great outcomes. And that's what we are, we're like the Avis. We provide really good service at a better price, and in some cases we provide better outcomes. They call it, they'll call it in-network, out-of-network, and some places will do like a 1, 2, 3 tiering. So tier 1 might be covered. If St. Francis is one of your insurance's tier 1 places, you can go there for your care, it'll be paid for. If you choose to go to a tier 2 or an out-of-network, you're gonna pay more out of pocket for that. And that's happening now. So people see it, not so much with ER yet, but imaging studies. If you need an MRI, for example, they've got a better deal with those guys over there. And so it might cost the insurance $350 for that study there, whereas if you go to those cats over there, they charge us $500. You're going to be on that hook for the $150. And in time, I actually expect that will become tighter, where you will, you may not even be allowed to go out of network unless there's a very specific medical reason for that to be the case. Yeah, there are places, not so much in this region, but other parts of the country, where if you sign up for Kaiser Permanente, you get all your care in Kaiser Permanente. If you sign up for, and there are other places that Geisinger Clinic, that's what they like. In Connecticut is still kind of, we're a slow adapter in healthcare. Actually, even though we have some great healthcare institutions, we're not as advanced along that value equation as other states are, but we're moving there quickly, like I said. And when it happens, it's going to be a big impact. So hospitals that can provide really good care at a better price are going to win out over those that are just based on their reputation, their marketing and advertising, because employers they're the ones who are paying the bills.
That is that question, but I think people want to.
Yeah, I think one more question is fine, so you can ask.
This leads very well into my question, which is kind of complicated, but maybe a silly question. So I had a few years ago, I got heart ablation, and I didn't know how much it cost. It was covered through the military, but I got the bill, obviously, and it was like $55,000. And I was just curious, like, what metrics and logistics and factors go into, we're going to evaluate this procedure or this medicine or this person or this service at this cost. And then why is it so different between companies? Does it come back to ultimately how much increased the price of college is, whether you're, pre-med or you're a veterinarian or whatever you do, college is increased exponentially more than anything else, like wages or, other things that increase. Same with cars, like everything has increased in how much it costs, but isn't the value still pretty much the same?
eventually, all the costs get really sort of passed along in healthcare, just like anything else. So we either collect it through premiums of commercial insurances, or we, sometimes people get on philanthropic campaigns to get money to buy things. But I think that's the future debate in healthcare, actually, is there any way to change the cost curve? Because you saw with that Massachusetts thing. As long as it keeps going up,
You have to pay for the equipment, you have to.
Somebody's
pay for
gonna
the
have to
stuff
pay
make
for
your
it.
hospital
Right.
operate, I understand it all costs money, but if I'm just one patient and you're getting 55,000 from the government, because I was military covered, and there's no copay, then like how much money are they really making? And where is it going? It's just like our country, like, where does the tax money go?
I don't know if I can answer that question, but your healthcare dollars, like,
The money is being made,
it's
being taken.
it's a very subtle question. So we do get, if you broke down a service like EP studies, like electrophysiology studies that you
Right.
had, and compared it to, let's say, a hernia operation, the profit built into that 55,000, I guarantee you, is considerably higher than the profit margin that's built into the hernia operation. So as a general rule, at least early on, new things cost more to develop, cost more to implement, train people, et cetera. And so they, in our, again, pretty free marketplace, they cost more, and you get a greater return on it. When you aggregate that all, though, like I said, if you look at how hospitals, if you get a 4% margin all in, because we're providing behavioral health services, uncompensated care, et cetera. So another way of looking at it is, and the cardiologists, they do this all the time, they say, or it's usually orthopedic surgeons, we're bringing in a lot of money, so whatever we want to get. We don't mind if you take some of it and use it for other stuff, but the truth of the matter is the hospital profits are being driven by orthopedics and cardiology, so we're special. And actually, people do talk like that sometimes. I hate to say it. And they're not wrong, but why they're actually receiving more is a historical artifact, which I could actually talk more about. Do you know what an average GP like me made in the 1930s? Income? What? 40 grand. No, 3 grand. And do you know how? Yeah.
My bad, in the 30s, I'm just under these guys.
And a specialist would make about 4,500, 5,000. So,
I'm not actually zero.
right? Why we pay people differently based on what their discipline is or what they do, there are reasons why our system developed that way.
Because if we looked into that, could we solve some of our problems?
Well, that's think about the conversation you need to have even within the family of healthcare. If you're gonna go to the orthopedic surgeons or the cardiologists, who, by the way, they train twice as long as I did once they finished medical
So
school.
how much medical school you do?
Not medical school, medical school's the same.
Right.
So if you're gonna be a cardiothoracic surgeon, after medical school, you've got 7 years of additional training ahead of you. Whereas I'm a primary care doctor, I have 3 years of additional training. Whether or not, how much that's worth in revenue or annual income, that's a conversation you can have. I would say, as a general matter of fairness, I think someone who's that specialized and that trained, because there's so much fewer, they're always going to command more income. But remember, the income part is just part of it. You know, that $55,000 didn't go to the doctor who's working for the
I
VA.
didn't assume it did at all. I assumed.
In fact,
it had
he's
to go
probably
pay-
on salary and gets what he gets.
Right,
She
I
gets.
assume it has to go to pay the bills of running the hospital,
Yeah.
because if you don't have an open hospital, you can't take patients, and you have no revenue.
Right.
So that, I mean, that pretty much
That's
answers
the
my
case.
question.
Yep.
But my solution would be legalize drugs, and people are doing money, and taking money in the card. But nobody likes that idea, 'cause it's too complicated, but
I don't think it's complicated, I just think it's a bad idea.
people are doing drugs and dying and not seeking.
All
help
right.
anyway, so.
Thank you. So one thing I wanted to say is, he's not my doctor, but I think I'd want him to be,
because
Of course.
the fact that he can explain such complex things in such simplified ways so that I can understand them was awesome. So thank you so much.
Thank you. Thank you all.